Usually when we talk about a medical diagnosis, there's this underlying assumption of like structural precision.
Right, yeah.
It's highly mechanical. I mean,
Yeah.
a patient fractures a femur, the radiograph reveals the displaced cortex, and the orthopedic surgeon just points to the film.
Mm-hmm.
They identified the exact mechanical failure.
Exactly. The problem is visible.
Yeah, it's categorized, and the solution, well, the fixation is entirely anatomical.
It is, and it's a really comforting paradigm. I
Mm.
mean, the human brain prefers binary states, right? Broken or intact, obstructed or patent,
Mhm.
resectable or unresectable.
Totally.
And for over a century, that anatomical binary logic was the absolute foundation of surgical oncology.
But the moment you step into the modern landscape of hereditary colorectal cancer, that strictly anatomical framework just collapses.
Oh, completely. It falls apart.
Right. We are looking at a diagnostic and therapeutic reality
Mm-hmm.
where evaluating the tumor purely based on its physical size and location is, well, it's practically archaic.
Yeah, it really is.
If you're only looking at the gross anatomy, or even just the standard histology, you're essentially operating in the dark.
You're looking at the hardware while completely ignoring the software.
Oh, I like that analogy.
Yeah, and until you zoom in to the molecular level, I mean, until you sequence the specific genetic code driving that particular tumor, you really cannot formulate a rational treatment plan.
Right.
It is the definition of diagnostic muddy waters until you apply that molecular lens.
Which brings us to our mission today. So, welcome to the deep dive. We are speaking directly to you, the dedicated learner. We know the exact position you're in right now.
We've been there.
Absolutely.
Mm-hmm.
You might be deep into your preparation for the FRCS exam, meticulously reviewing those surgical algorithms. Or maybe you're gearing up for a PhD defense in molecular oncology, dissecting survival curves and hazard ratios.
Or, you're a practicing clinician who just refuses to settle for memorizing surface-level flowcharts.
Exactly. You want to understand the architectural logic beneath the guidelines. You want the granular truth of how we actually manage hereditary colorectal cancer today, right from the statistics down to the cellular pathophysiology.
And we are approaching this with the absolute rigor it demands. Because the overarching philosophy you really must internalize before we begin is this: hereditary colorectal cancer is not a monolith.
No, not at all.
It is not a single disease entity that responds to, a universal protocol.
Mhm.
It requires an intensely multidisciplinary approach. And every single decision, from the timing of the scalpel to the specific sequence of cytotoxic drugs, is dictated by incredibly precise genetic findings and the unique biology of the tumor microenvironment.
Okay, let's unpack this shift in perspective.
Hmm.
Because the historical narrative we were all taught is essentially a search and destroy mission, right?
Yeah. Find it and cut it out.
Exactly. You identify the primary tumor, you surgically resect it with wide margins, you flood the systemic circulation with chemotherapy to eradicate any micrometastatic disease, and then, well, you just monitor the scans.
Right, wait and see.
But we are currently navigating a profound, fundamental shift in oncology. We've reached a point where knowing the exact molecular signature of a tumor doesn't just tweak the treatment algorithm, it completely flips it.
It's a total inversion.
Yeah. We're going to examine scenarios today where traditional standardized chemotherapy is not just ineffective, but actively detrimental to the patient's survival.
And that realization is the pivot point of modern archaeological practice. I mean, we've transitioned away from relying solely on TNM staging.
Right, the whole how deep has it invaded and which lymph nodes are involved.
Exactly. We've moved from that to prioritizing molecular profiling. We're interrogating the tumor to ask what specific genetic mutation is driving this uncontrolled proliferation. Because if you misidentify the driver mutation, you will deploy the wrong therapeutic agent, and the cancer will simply bypass your intervention.
So we have to start by examining the heavy artillery, right, and the statistics that justify their use. Let's look at the foundational rules of systemic chemotherapy and targeted therapies.
Because to understand the molecular exceptions, you first have to understand the baseline standards.
Exactly. So when a patient has undergone a successful surgical resection of the primary tumor, we enter the adjuvant setting. And the guidelines from the NCCN, ASCO, and ESMO are extremely specific regarding stage 2 and stage 3 colorectal cancers.
Right. The risk stratification here is paramount. For stage 2 cancers, where the tumor has invaded through the bowel wall but hasn't yet reached the lymph nodes, the guidelines do not recommend blanket adjuvant chemotherapy.
They don't. We specifically look for high-risk features, right?
Right.
Like a T4 lesion, bowel perforation or obstruction at presentation, or inadequately sampled lymph nodes.
Yes. And crucially, adjuvant therapy is only recommended for these high-risk stage 2 patients if their tumor exhibits proficient mismatch repair, what we term PMMR, or if they're microsatellite stable, MSIS.
Right. And for stage 3 cases where regional lymph node metastasis is confirmed, adjuvant therapy is universally recommended.
But the logistical detail that consistently appears on board exams and honestly dictates clinical outcomes is the initiation window. The guidelines mandate starting adjuvant chemotherapy, typically the FOLFOX or FOLFOX regimens, within a strict 6 to 8 week window following surgical resection.
Okay, I really want to dissect that timeline. Why that specific window? I mean, if the goal is to eradicate residual microscopic disease, why not initiate systemic therapy at 3 weeks, the moment the patient is discharged?
Pick your question.
Or conversely, why not allow them a full 12 weeks to completely regain their physiological baseline before introducing highly toxic agents?
Well, it is an incredibly delicate negotiation between surgical wound healing and the kinetics of micrometastases. If you initiate cytotoxic therapy too early, say at 3 weeks, you're introducing drugs designed to halt cellular replication into a patient whose survival depends entirely on cellular replication.
Right, because of the surgery.
Exactly. The patient's anastomosis, the surgical connection between the two ends of the bowel, is still actively remodeling. The immune system is engaged in resolving the massive inflammatory cascade triggered by the laparotomy.
And if you administer a pyrimidine analog that stops DNA synthesis,
You completely arrest that healing process. You risk catastrophic anastomotic leaks, fascial dehiscence, and overwhelming sepsis.
oh wow. So you are essentially paralyzing the body's repair mechanisms while the structural integrity of the gut is still, compromised.
Exactly. But on the flip side, you cannot afford to wait indefinitely. If you delay beyond 8 weeks, you run into the problem of the angiogenic switch.
The angiogenic switch, right.
Yeah. During surgery, microscopic clusters of cancer cells might be seeded into the bloodstream or lymphatic system. Initially, these micrometastases are incredibly vulnerable. They're floating clusters without an established blood supply, relying on simple diffusion for oxygen.
So they're highly susceptible to chemotherapy at that point.
Very susceptible. However, if you give them 10 or 12 weeks, they begin secreting vascular endothelial growth factor, or VEGF. They sprout their own capillaries.
Wow, they build their own infrastructure.
Right. They transition from vulnerable floating cells to established, resilient, self-sustaining secondary tumors. So that 6 to 8 week window is the precise biological sweet spot where the anastomosis is structurally secure, but the micrometastases haven't yet established their own vascular infrastructure.
That makes the clinical timing much more logical. You're really threading the needle between surgical morbidity and ontological escape.
You really are.
So let's examine the actual regimens deployed in that window, starting with the foundational first-line treatments for metastatic CRC FOLFOX and FOLFIRI. We need to look at the pharmacology here. So FOLFOX is a combination of 5-fluorouracil, leucovorin, and oxaliplatin.
Right, and the evolution of FOLFOX is a masterclass in pharmacological synergy. I mean, for decades, the standard of care was single-agent 5-fluorouracil, or 5-FU.
Which is a pyrimidine analog.
Exactly. It structurally mimics uracil, which is a fundamental building block of RNA and DNA. So when the rapidly dividing cancer cell attempts to replicate its genome, it mistakenly incorporates the 5-FU into its sequence.
Like a fake brick in the wall.
Yeah, and that fake brick irreversibly binds and inhibits thymidylate synthase, completely halting DNA replication. But as a monotherapy, its efficacy was actually pretty limited.
Right, so they needed to boost it.
Which led to the first major enhancement, the addition of leucovorin, which is folinic acid. Now, leucovorin doesn't kill cancer cells directly.
Wait, it doesn't? Then what does it do?
Instead, it stabilizes the bond between 5-FU and thymidylate synthase. It essentially locks the poison onto the target enzyme, drastically increasing the duration and intensity of the DNA replication blockade.
Oh, that's clever. And then the field introduced oxaliplatin to create the full FOLFX regimen.
Correct. And oxaliplatin is a third-generation platinum-based anti-neoplastic agent. It operates via a completely distinct mechanism. Once inside the cell, it undergoes equation and binds directly to the DNA, forming bulky intrastrand and interstrand crosslinks.
So it physically blocks the replication machinery.
Exactly. When the cell's machinery tries to unzip the DNA double helix to copy it, it hits these platinum crosslinks and physically cannot proceed. The DNA strand breaks, triggering apoptosis. You are hitting the cancer cell's replication cycle from two entirely different angles simultaneously.
And the statistical impact of this combination fundamentally rewrote the prognosis for these patients, right?
Oh, absolutely.
Because when evaluating the clinical trials comparing the FOL-FOX combination to the older standard of single-agent 5-FU, the progression-free survival, the PFS, demonstrated a hazard ratio of 0.59 with a 95% confidence interval of 0.49 to 0.73 across two massive randomized controlled trials.
Which is huge.
Yeah. Furthermore, the overall survival, the OS, showed a hazard ratio of 0.69. So for a clinician evaluating the strength of this data, what does a hazard ratio of 159 actually translate to when you are standing at the bedside?
It represents a tectonic shift in efficacy. In biostatistics, a hazard ratio of 1.0 indicates absolute equivalence between the experimental arm and the control arm. Neither is better.
Right, it's a wash.
Yeah. So a hazard ratio of 0.59 for progression-free survival means that at any given moment during the trial, a patient receiving the FOL-UPS regimen experienced a 41% lower risk of their cancer progressing compared to a patient receiving only 5-FU.
Wow, you've nearly halved the velocity of the disease.
Exactly. And the overall survival hazard ratio of 0.69 translates to a 31% reduction in the relative risk of death. In the context of metastatic solid organ malignancies, achieving a 31% reduction in mortality simply by altering the chemotherapy combination is an extraordinary clinical triumph.
So we establish FOLFOX as a primary pillar. But drug resistance or severe side effects, particularly that debilitating peripheral neuropathy caused by oxaliplatin, well, they often require a shift in strategy.
Right. Patients just can't tolerate the numbness and pain.
Exactly. Which brings us to FOFIRE, which substitutes the oxaliplatin for irinotecan.
And irinotecan introduces yet another mechanism of action. It's a topoisomerase I inhibitor. So, during normal cellular division, as the DNA double helix is rapidly unzipped by helicase, severe torsional strain builds up ahead of the replication fork.
Right, like rapidly pulling apart the strands of a tightly twisted rope, it knots up.
Perfect analogy. Topoisomerase I normally solves this by creating temporary reversible single-strand nicks in the DNA, allowing it to swivel and relieve the tension before resealing it.
And irinotecan stops the resealing.
Exactly. Irinotecan binds to the topoisomerase I DNA complex and prevents the resealing process. So when the replication fork collides with this unsealed nick, the DNA double strand completely shatters. It is lethally disruptive to the cell.
And FOLFIRI demonstrates comparable efficacy to FOLFOX, right? With an overall survival hazard ratio of 1.58 against historical comparators.
Yes. Crucially, irinotecan-based combination therapies vastly outperform irinotecan monotherapy, improving progression-free survival with a hazard ratio of 0.68 across 6 distinct randomized controlled trials.
So we have these two immensely powerful cytotoxic regimens, FOLFOX and FOLFIRI, designed to indiscriminately shatter the DNA of any rapidly dividing cell. But the paradigm shifted again when we moved beyond simple cytotoxicity.
Right, the era of biologics.
Exactly. The field began integrating targeted agents, specifically monoclonal antibodies, into these base regimens. And the pioneer in this space was bevacizumab.
And bevacizumab targets the exact mechanism we discussed earlier regarding the angiogenic switch. It's a recombinant, humanized monoclonal antibody directed against vascular endothelial growth factor A, or VEGF-A.
Because tumors need blood.
Exactly. Solid tumors cannot grow beyond 1 or 2 millimeters in diameter without establishing their own blood supply. Simple diffusion just is no longer sufficient to provide oxygen and nutrients to the core of the tumor mass.
So the tumor survives by pumping out massive quantities of VEGF to stimulate the surrounding host vasculature to sprout new capillaries directed toward the tumor bed.
Right, and bevacizumab acts as a sponge in the systemic circulation, binding to VEGF-A and neutralizing it before it can reach the endothelial receptors. It essentially starves the tumor by inhibiting neoangiogenesis.
Now, the clinical trial data surrounding bevacizumab provides a really fascinating lesson in how biostatistics and medical ethics intersect.
It really does. It's a classic example.
We have the AVF2107G trial, which clearly demonstrated a significant overall survival benefit when bevacizumab was added to the older IFL regimen. But the pivotal trial for modern regimens is N016966.
Right, the FOL-FOX ELO-X trial.
Yeah. This trial evaluated the addition of bevacizumab to FOL-FOX, or XELO-X. It demonstrated a statistically significant improvement in progression-free survival, 9.4 months versus 8.0 months, with a highly significant p-value of 0.00023.
Very robust PFS data.
But it failed to show a statistically significant benefit in overall survival, and the primary reason cited by the investigators was crossover.
And crossover is a critical concept that every clinician absolutely must understand when interpreting modern oncological literature. It perfectly illustrates how the ethical imperative to treat the patient can directly compromise the statistical purity of the trial's ultimate endpoints.
Right. To make this concrete, let's walk through a hypothetical scenario of how this crossover actually corrupts the overall survival data.
Okay, let's do it.
Let's say we have patient A who is randomized into the control arm receiving only FOLFOX, and patient B who is in the experimental arm receiving FOLFX plus bevacizumab.
Exactly. At the beginning of the trial, the two arms are distinctly separated. Patient A is your true control.
Right. As the trial progresses, the investigators measure progression-free survival. They observe that patient B goes 9.4 months before their scans show the tumor growing again, while patient A's tumor starts growing at 8.0 months.
Right, and the PFS endpoint is captured cleanly because it is measured the exact moment the cancer progresses. The bevacizumab clearly delayed the progression, but here is where the ethics intervene.
Right, because patient A is getting worse.
Exactly. Once patient A's cancer progresses, the trial investigators are looking at data showing that the experimental drug works for patient B. Ethically, they cannot justify keeping patient A on a failing regimen just to see how quickly they die for the sake of a clean overall survival Kaplan-Meier curve.
Yeah, the Institutional Review Board would never allow them to withhold a proven beneficial drug.
So they allow patient A to cross over and begin receiving bevacizumab as a second-line treatment. But when the statisticians calculate the overall survival endpoint years later, patient A is still categorized in the control group based on the intention to treat principle.
Oh, I see. However, patient A's ultimate survival was likely artificially prolonged by receiving the experimental drug later in their course.
Precisely. The control arm was contaminated. Because both groups eventually received the drug, the overall survival curves merge, and the p-value becomes statistically insignificant.
But the drug still works.
Exactly. Yet, because the progression-free survival benefit was so robust and biologically plausible, bevacizumab was firmly established as a standard first-line adjunct for metastatic CRC, despite the lack of a clean OS p-value in that specific trial. You have to synthesize the entirety of the clinical picture, not just worship a single isolated p-value.
That is a vital lesson in evaluating trial design. But we need to move from trial mechanics to the sheer geographical complexity of the colon itself, because this is where the narrative becomes incredibly counterintuitive.
On the sightedness data, this changes everything.
It really does. The Taylor and Prime meta-analyses evaluated the addition of a different class of monoclonal antibodies, anti-EGFR agents, specifically cetuximab and panitumumab, to the FOLFOX regimen. And the patient population was strictly those with KRAS, NRS, and BRAF wild-type metastatic CRC. Wild-type meaning their tumors did not harbor mutations in these specific downstream signaling genes. The meta-analysis revealed that the survival benefit of these advanced biological drugs was entirely dependent on which side of the colon the primary tumor originated from.
It was a revelation that forced the entire oncological community to completely reevaluate their fundamental understanding of colonic anatomy. For centuries, the colon was treated as a single, continuous, uniform tube of endoderm.
Wait, I have to challenge this premise entirely.
Go for it.
If the tumor is genetically identical, if we have confirmed through next-generation sequencing that both a right-sided tumor and a left-sided tumor are completely RAS wild-type and BRAF wild-type, why should their physical zip code in the abdomen matter at all?
It's the logical question to ask.
If the genetic software driving the receptor is identical, shouldn't the anti-EGFR drug crash that software exactly the same way, regardless of whether the tumor sits in the cecum or the descending colon? What biological variable are we missing here?
It's a brilliant question, and the answer lies deep in human embryology. The colon is actually not a uniform structure. It is a fusion of two entirely distinct embryological organs that just happen to meet in the middle.
Oh, wow. Okay.
The right side of the colon comprising the cecum, ascending colon, and the proximal two-thirds of the transverse colon originates from the embryonic midgut. Its primary vascular supply is derived entirely from the superior mesenteric artery.
Right.
But the left side of the colon, the distal third of the transverse colon, descending colon, sigmoid colon, and rectum, originates from the embryonic hindgut. And its vascular supply is entirely from the inferior mesenteric artery.
Two completely different origins.
Because they represent two different developmental lineages, their underlying molecular landscapes, their baseline gene expression profiles, and their distinct immunological microenvironments are fundamentally different.
So an identical mutation behaves differently because the cellular background it operates within is embryologically distinct.
Precisely, and the data from the meta-analyses is stark. If you administer an anti-EGFR drug like cetuximab to a patient with a left-sided wild-type tumor, the overall survival hazard ratio is an impressive 0.71 with a highly significant p-value of 0.0002. It works beautifully.
Okay, but what about the right side?
If you administer that exact same drug to a patient with the exact same wild-type genetic profile, but the tumor originated on the right side of the colon, the hazard ratio jumps to 0.90 and the p-value is 0.53. It is statistically useless.
That's wild. Wow.
The reason is that right-sided tumors, due to their midgut origin, utilize alternative signaling pathways to sustain their growth. Left-sided tumors are highly dependent on the epidermal growth factor receptor pathway. If you block EGFR in a left-sided tumor, you effectively cut off its primary growth signal.
But the right side has a backup generator.
Exactly. A right-sided tumor doesn't rely on EGFR as its primary engine. You can blockade the EGFR receptor completely, and the right-sided tumor will simply shrug it off and utilize a different physiological backdoor, such as the 1-beta-catenin pathway or varied immunologic escapes, to continue proliferating. The zip code dictates the dominant biological pathway.
Anatomy is destiny, because anatomy dictates the baseline molecular biology. It is a profound realization. And staying on the topic of specific molecular targets, we have to look at the absolute bleeding edge of targeted therapy, the Breakwater trial.
Yes, the new standard for BRAF.
Right. This trial resulted in an accelerated FDA approval in December 2024. It focused on a highly specific subset of metastatic CRC patients harboring the BRAF V600E mutation.
And the BRAF V600E mutation has historically been one of the most feared prognostic indicators in colorectal oncology.
Why is that?
Well, BRAF is a kinase that sits downstream of EGFR in the MIPK signaling pathway. The V600E mutation involves a single amino acid substitution valine to glutamic acid at position 600. That microscopic structural change locks the BRAF kinase into a constitutively active state.
So it's always on.
It is permanently stuck in the on position, continuously firing signals to the nucleus to divide and proliferate, completely independent of any upstream signals. Historically, these tumors were wildly aggressive, rapidly metastatic, and demonstrated profound intrinsic resistance to standard cytotoxic chemotherapy.
But the Breakwater trial completely revolutionized the approach to this aggressive variant. Instead of relying solely on heavy cytotoxicity, they designed a triple threat regimen.
A very elegant regimen.
They utilized the standard FOLFOX chemotherapy backbone, but they added encorafenib, which is a highly specific targeted BIF inhibitor, and they simultaneously added cetuximab, the EGFR inhibitor we just discussed.
And the clinical results were staggering.
Yeah, the experimental arm achieved a 60.9% overall response rate compared to a mere 40% in the control arm receiving standard chemotherapy. And the median duration of response was significantly extended from 11.1 months to 13.9 months.
A massive jump.
Mechanistically, why use three different modalities? I mean, why add an EGFR inhibitor if the mutation is downstream in the BRAF kinase? If BRAF is the problem, shouldn't encorafenib alone be sufficient?
That is where the elegance of rational drug design comes into play. You have to anticipate the tumor's adaptive resistance mechanisms.
Okay, so what does the tumor do?
Well, if you administer encorafenib as a monotherapy, it successfully blocks the mutant BRAF kinase. The cell briefly stops proliferating, but the cancer cell possesses an incredibly robust negative feedback loop. When it senses that the downstream MAPK pathway has been shut down, it dramatically upregulates the expression and activity of EGFR on its cell surface to try and force the pathway back open.
It essentially builds more antennas to catch more growth signals.
Exactly. And if you don't block those new antennas, the tumor rapidly overcomes the BRAF inhibition. Therefore, you must deploy encorafenib to silence the mutant BRAF and simultaneously deploy cetuximab to blockade the compensatory surge in EGFR activity.
All while FOLFOX poisons the rapidly dividing cells that manage to escape the blockade.
Right. It is a comprehensive molecular siege. It establishes an entirely new, biologically rational first-line standard of care for the BRA V600E population.
When you lay out the pathophysiology like that, the trial design seems almost inevitably logical. But, all of this precise targeting, the chemotherapy cross-linking, the kinase inhibition, assumes that the tumor's fundamental DNA repair mechanisms are at least somewhat intact.
Right, which isn't always the case.
Exactly. When they aren't, the entire rulebook we just established gets thrown out. Which brings us to a distinct, game-changing molecular signature, microsatellite instability high, or MSI-H. This is the hallmark of Lynch syndrome, and its presence demands an entirely different therapeutic algorithm.
MSI-H represents an entirely separate paradigm in oncology. To grasp its clinical implications, we first have to define what a microsatellite actually is.
Okay, let's break it down.
Distributed throughout the human genome are thousands of short, tandemly repeating sequences of DNA, for example, a sequence of cytosine and adenine repeating dozens of times, like kakaka. Because these sequences are highly repetitive, they act like a genetic stutter.
So the replication machinery gets confused.
Exactly. When the DNA polymerase enzyme is rapidly copying the genome during cell division, it frequently slips on these repetitive tracks, accidentally adding or deleting a base pair.
It's essentially a high-speed transcription error.
Precisely. Now, to prevent these errors from becoming permanent mutations, normal cells possess a sophisticated spell-checking system composed of mismatch repair, or MMR, proteins specifically MLH1, MSH2, MSH6, and PMS2.
The spell checkers.
Right. These proteins constantly scan the newly synthesized DNA, identify the slipped mispairs, excise them, and correct the sequence. However, in patients with Lynch syndrome who inherit a mutated MMR gene, or in patients with sporadic tumors where the promoter regions of these genes undergo hypermethylation and epigenetic silencing, the spell checker is fundamentally broken.
The transcription errors are never fixed.
Never. The microsatellites rapidly expand or contract. This chaotic accumulation of errors is defined as microsatellite instability high.
And the presence of this profound instability leads us directly to what we can call the chemotherapy paradox.
So this is a mind bender.
It really is. For patients with early stage 2 MSI-H tumors, administering fluoropyrimidine-based chemotherapy alone, like the 5-FU we established earlier as the cornerstone of treatment, has shown virtually no survival benefit. In fact, the data suggests it may actually be detrimental in the adjuvant setting.
It's actively harmful.
Yeah. If you give a stage 2 MSI-H patient single-agent 5-FU, you might be actively shortening their life expectancy compared to doing nothing at all. Yet, if you use the combination FOLFOX therapy, you see positive outcomes for stage 3 MSI-H disease.
And it gets weirder.
Right. The paradox deepens further. The detrimental effects of single-agent 5-FU or FOLFOX completely evaporate if the MSI-H cancer is diagnosed in the metastatic setting.
They just vanish.
So, I need you to synthesize this for us. If a cytotoxic drug is actively harmful when treating microscopic residual disease in stage 2, why does that harm disappear when the disease is overwhelmingly present in stage 4?
It is a phenomenal paradox, and resolving it requires us to completely shift our focus from the cancer cell itself to the surrounding immune microenvironment. MSI-H tumors are uniquely immunogenic.
Because of all the errors.
Exactly. Because their spell checker is broken, they accumulate thousands of somatic mutations. These mutations result in the production of highly abnormal, truncated, or misfolded proteins, what we call neoantigens.
So the body sees them as foreign.
Yes. The patient's immune system, specifically the cytotoxic T cells, easily recognizes these neoantigens as completely foreign. In an early stage, stage 2 MSI-H tumor, the patient's native immune system is highly activated and is often already engaged in a robust, effective campaign to keep any microscopic residual disease suppressed.
So if we introduce single-agent 5-FU in that adjuvant setting, you aren't just failing to kill the tumor. You are actively disarming the patient's native immune response. You are shooting the guards.
That is the exact mechanism. 5-FU is inherently cytotoxic and mildly immunosuppressive. By administering it to a stage 2 patient, you systematically deplete their circulating lymphocytes.
Oh, wow.
You are chemically destroying the precise T cells that were successfully holding the micrometastatic cancer in check, while failing to effectively eradicate the highly mutated cancer cells themselves. You inadvertently remove the immune system's foot from the brake pedal, allowing the cancer to recur more rapidly than it would have without intervention.
But why does FFOX succeed in stage 3?
Because the oxaliplatin component of FOLFOX changes the nature of the cell death. Oxaliplatin doesn't just quietly halt replication, it induces what is known as immunogenic cell death.
Immunogenic cell death.
Right. It destroys the cancer cells in a highly inflammatory manner, causing them to rupture and spill massive quantities of those abnormal neoantigens directly into the local microenvironment alongside damage-associated molecular patterns, or DAMPs.
So it's like setting off an alarm.
Exactly. This sudden massive release of antigen acts essentially as an in vivo vaccine, hyperstimulating the immune system to such a degree that it overcomes the mild immunosuppressive effects of the 5-FU.
And what about the metastatic setting? Why does the detriment of single-agent 5-FU vanish in stage 5e disease?
Because the immunological context of the patient has fundamentally collapsed. In widespread metastatic disease, the sheer volume of tumor burden is astronomical. The immune system has been constantly exposed to neoantigens for months or years.
So they just give up.
Consequently, the T cells enter a state of profound exhaustion. They upregulate inhibitory receptors and essentially shut down. They're completely overwhelmed and functionally inert.
The guards are already asleep.
Right. Therefore, administering an immunosuppressive drug like 5-FU in the metastatic setting doesn't cause the same detrimental release of the brakes because the brakes have already burned out completely. At that stage, the direct cytotoxic effect of the drug on the massive tumor volume becomes the primary measurable clinical effect, bypassing the immunological detriment we observed in the early-stage adjuvant setting.
The microenvironment completely dictates the drug's true efficacy. But, we cannot discuss exhausted T cells and MSI-H tumors without immediately transitioning to the immunotherapy revolution.
The biggest game changer we have.
If the T cells are exhausted, how do we wake them up? We deploy immune checkpoint inhibitors, specifically monoclonal antibodies targeting the programmed death receptor 1, or PD-1.
Because tumors have evolved incredibly deceptive mechanisms to evade immune surveillance. They frequently express a surface protein called PD-L1. When a cytotoxic T cell approaches the tumor to destroy it, the tumor's PD-L1 protein binds tightly to the PD-1 receptor on the surface of the T cell.
It's like a secret handshake.
It is, and that physical binding event transmits a powerful overriding inhibitory signal into the T cell, effectively turning it off. It is the molecular equivalent of the tumor wearing an invisibility cloak, chemically instructing the immune system, I am normal self-tissue, do not attack.
And the drug pembrolizumab is designed to strip that cloak away.
Exactly. Pembrolizumab is a highly specific anti-PD-1 monoclonal antibody. It physically blocks the PD-1 receptor on the T cell, preventing the tumor's PD-L1 from binding to it. The inhibitory signal is severed.
So the T cells wake up.
Instantly.
Yeah.
The T cells reactivate, recognize the massive payload of neoantigens presented by the MSI-H tumor, and initiate a devastating coordinated immunological attack. And the clinical validation for this mechanism is the KEYNOTE-177 trial. This trial evaluated pembrolizumab as a frontline therapy for metastatic MSI-H, or mismatch repair deficient colorectal cancer. The results were unprecedented. Pembrolizumab absolutely dominated standard chemotherapy, demonstrating vastly superior progression-free survival and inducing incredibly deep, durable responses. We are observing patients with widely metastatic, historically lethal disease achieving sustained, complete remissions with a fraction of the traditional cytotoxic side effects.
And the field is pushing the boundary further by exploring dual blockade, right? They're combining PD-1 inhibitors with agents that block CTLA-4, which is a different immune checkpoint pathway operating earlier in the T-cell activation cycle.
Yes, attacking it from two sides.
The preliminary data suggests this dual blockade significantly improves overall disease control without exponentially increasing severe autoimmune toxicity. But the clinical arena where my mind is truly blown by immunotherapy is the neoadjuvant setting.
Oh, the NISO-E data.
Yeah. This involves administering the therapy before the surgical resection of an early-stage colon cancer. Now, historically, administering neoadjuvant chemotherapy for early-stage colon cancer has been an exercise in futility.
Yeah.
The Foxtrot trial specifically investigated neoadjuvant chemotherapy for MSI-H tumors, and the results were dismal. A pathetic 7% major pathological regression rate.
From a pathological standpoint, a 7% regression rate is essentially statistical noise. It is practically indistinguishable from spontaneous necrosis. It demonstrated that neoadjuvant cytotoxicity was just useless for this specific genetic profile.
Right. But then the paradigm shifts to neoadjuvant immunotherapy. We look at the data from the NICHE-1 and NICHE-2 trials. The investigators administered brief 4-week courses of immunotherapy prior to surgery for early-stage MSI-H colon cancers.
And the results are staggering.
They are not just an incremental improvement, they border on the miraculous. Niche 1 reported a 97% major pathologic response, or MPR. Niche 2 confirmed this with a 95% MPR, and with longer follow-up, there have been absolutely zero recurrences. For the FRCS candidate listening who is trying to visualize this, what exactly does a 95% major pathologic response look like to a pathologist examining the resected tissue?
It looks like an absolute ghost town.
A ghost town.
Yeah. When the surgical oncologist resects the segment of the colon and delivers it to the pathology department, the pathologist sections the tissue and examines it microscopically. Historically, with the standard resection, they would observe dense, chaotic sheets of aggressive, actively dividing adenocarcinoma cells invading the submucosa and muscularis.
The typical cancer slide.
Right. But after neoadjuvant immunotherapy in these niche trials, they see profound destruction. They see nothing but empty mucin pools, dense fibrotic scar tissue, and massive, overwhelming infiltrates of lymphocytes and macrophages clearing the debris. A 95% MPR dictates that 95% of the viable tumor mass has been completely eradicated by the patient's own immune system prior to the scalpel ever touching the tissue. It is a total, overwhelming, systemic victory.
It's astounding. It completely validates the underlying biology. And there are massive ongoing trials, PICC, Niche 3, and Imhotep, that are leveraging these response rates to focus entirely on organ preservation. They're asking the ultimate question. If the pathological response rate is 97%, do we even need to perform the morbid surgical resection at all?
But this data requires us to ask a profound mechanistic question. Why does immunotherapy work so spectacularly well, achieving near total eradication in the neoadjuvant setting, while in the metastatic setting, the responses, though excellent, rarely achieve that universal 95% complete eradication rate? What is the biological difference?
Let's deduce this based on the anatomy and the immune system's required infrastructure. If you administer the drug while the primary tumor is still intact inside the body,
you are preserving the entire battlefield and the training ground. In the neoadjuvant setting, the primary tumor microenvironment is fully intact. Crucially, the regional draining lymph nodes, the exact anatomical locations where naive T cells are presented with antigen and activated, are still physically present and functionally connected to the tumor via the lymphatic channels.
so the infrastructure is all there.
Exactly. The primary tumor acts as a massive centralized antigen depot. When you administer the checkpoint inhibitor, you are unleashing the T cells right at the source in the presence of maximum antigen density with fully operational lymphatic architecture to support massive clonal expansion of the immune cells.
They learn exactly what to kill.
Yes. The immune system learns precisely what to attack, scales up an enormous army locally, and circulated population of memory T cells that patrol the systemic circulation to hunt down and destroy any distant micrometastases.
The tumor essentially becomes its own personalized, highly potent vaccine generator, fueled by the checkpoint blockade. But if you perform the surgery first,
If you perform the upfront surgical resection, as we have done for a century, you violently remove the primary antigen depot. More importantly, you surgically excise the draining lymph nodes. You physically destroy the immune system's primary training ground.
you're taking away their intelligence data.
Exactly. When you subsequently administer the immunotherapy in the adjuvant setting, the immune system is severely blunted. It lacks the concentrated antigen and the localized lymphoid architecture necessary to mount that massive, coordinated systemic response. The neoadjuvant approach leverages the patient's intact anatomy to maximize the pharmacological effect.
That is a total conceptual inversion of the traditional cut it out as fast as possible surgical dogma. It is brilliant. Okay, so we have dived extensively into the granular molecular behavior of the tumor itself, the BRAF kinase mutations, the microsatellite instability, the immune microenvironment. But now we need to dramatically widen our lens.
We have to.
We need to connect this microscopic gut pathology to the broader systemic picture. Because hereditary colorectal cancer rarely exists as an isolated phenomenon in a vacuum. It frequently presents as merely one component of highly complex, multi-system congenital syndromes.
This is a critical pivot, particularly for clinicians. If you develop tunnel vision and focus exclusively on the colonic mucosa, you will fail the patient entirely. The specific genes that drive these hereditary colon cancers are not restricted to the gut. They are fundamental, ubiquitous regulators of cellular growth and differentiation throughout the entire human body.
Let's focus our attention on the specific mutations involving the PTEN gene homologs. PTEN functions primarily as a potent tumor suppressor gene. Correct.
The PTEN gene encodes a critical phosphatase enzyme. Mechanistically, PTEN acts as the primary overriding brake pedal for the PI3-KTM-TOR intracellular signaling pathway.
What does that pathway do?
That specific pathway is the cellular engine for survival, proliferation, and angiogenesis. When the PI3K pathway is active, it signals the cell to grow and divide aggressively. PTEN's job is to continuously dephosphorylate specific lipid second messengers, thereby shutting the pathway down and halting cell growth.
So what happens if PTEN is mutated?
If a patient inherits a germline mutation that results in the loss of PTEN function, that critical brake is permanently removed. The PI3KA10-TM-TOR pathway is locked into perpetual overdrive. The cells don't necessarily transform immediately into malignant carcinomas. Initially, they simply grow excessively, everywhere in the body.
Which perfectly elucidates the profound and varied clinical phenotypes associated with these mutations. Let's examine Solomon syndrome. This condition is categorized within the broader Cowden syndrome spectrum, fundamentally driven by these germline PTEN mutations.
And the physical exam findings are very distinct.
The clinical characteristics are striking. Segmental overgrowth of limbs or tissues, profound lipomatosis, which is the massive, uncoordinated overgrowth of mature adipose tissue, arteriovenous malformations, or AVMs, and the presence of epidermal nevus, which present as thickened, hyperpigmented linear patches of skin.
It's all connected.
It illustrates a devastating genetic domino effect. A single misfiring phosphatase enzyme doesn't just increase the risk of an intestinal polyp. It cascades into profound architectural derangements in the vascular system, the skeletal structure, and the integumentary system.
When you understand the underlying pathway overdrive, it fundamentally alters how you conduct a standard physical examination. You are no longer solely interrogating the patient for vague abdominal pain or checking for occult blood in the stool. You are actively inspecting the cutaneous surfaces, palpating for unusual subcutaneous masses, and looking for vascular anomalies.
Exactly. And this systemic approach is equally vital when evaluating Banan-Riley-Ruvalcaba syndrome.
That's a mouthful, but very important.
It is. This is a rare congenital disorder characterized by the development of hamartomatous intestinal polyps. But systemically, the patient presents with multiple lipomas, striking macrocephaly, an abnormally large head circumference, and genital antigenosis, which are distinct, heavily pigmented macules on the genitalia.
And the cancer risk is the key here.
Right. The critical oncological statistic that every clinician must remember here is that patients diagnosed with Banan-Riley-Ruvalcaba who are confirmed to carry the specific PTEN mutation share the exact same elevated lifelong cancer risk as patients diagnosed with classic Cowden syndrome.
And that elevated risk profile is expansive. It is not limited to the colorectal tract. These patients face aggressively high risks for early-onset breast cancer, follicular thyroid cancer, and endometrial carcinoma.
But the macrocephaly is interesting. Why does their head grow so large?
The presentation of macrocephaly is mechanistically fascinating. The infant's brain is physically growing too rapidly during crucial developmental windows because the neural progenitor cells lack the PTEN brake on the PI3K pathway.
So it's just unregulated brain growth.
Therefore, a pediatrician accurately recognizing an abnormally large head circumference, combined with perhaps a few unusual skin tags, could be the crucial first step that flags the child for genetic testing, initiating a lifetime of intensive multi-organ cancer surveillance that ultimately saves their life.
The final syndrome in this systemic category, and one that is notoriously favored by FRCS examiners, is Proteus syndrome. The clinical presentation is defined by severe, progressive, asymmetrical, excessive growth affecting the skeleton, the skin, adipose tissue, and the central nervous system.
It's a very severe phenotype.
These patients do develop hamartomatous polyps in the gastrointestinal tract, but these polyps are typically benign and rarely undergo malignant transformation. The reason examiners focus so heavily on Proteus syndrome is not the cancer risk, but rather the devastating, often lethal systemic complications associated with the profound tissue overgrowth.
The complications are catastrophic.
We are talking about hemimegalencephaly, a condition where one entire hemisphere of the brain grows drastically larger than the other, causing intractable seizures, along with severe bullous lung disease, massive pulmonary embolisms, and deep vein thrombosis.
Proteus syndrome is mechanistically distinct. It is essentially a mosaic genetic disorder. It is typically driven by a somatic, postzygotic activating mutation in the AKC1 gene, which sits directly downstream of PTEN in that same cellular pathway.
So it's the same pathway, just a different broken switch.
Yes. It is frequently discussed in the differential diagnosis for PTN overgrowth syndromes because the clinical endpoints of the pathway overdrive are so similar. The vascular complications are the primary cause of mortality.
Because of all the extra tissue.
The massive unregulated overgrowth of soft tissue and bone creates enormous, disorganized, low-flow vascular beds in the hypertrophied limbs. These dilated, sluggish vascular networks are highly prone to profound venous stasis, creating the perfect physiological storm for the development of massive, deep vein thromboses and subsequent lethal pulmonary emboli. Additionally, the severe progressive skeletal deformities can become profoundly disabling, requiring highly complex orthopedic interventions.
The clinical takeaway is paramount. If you are a physician examining a patient who presents with a vague family history of colon polyps, and during the exam you identify an epidermal nevus on their torso, or you note a history of macrocephaly in their pediatric chart.
You absolutely do not just schedule a routine colonoscopy, hand them a prep sheet, and consider your job done. You must immediately refer that patient to a specialized clinical genetics team.
It changes everything.
You must operate on the high clinical suspicion of a PTN hamartoma tumor syndrome, because identifying that specific germline mutation completely dictates their future. It alters their entire life trajectory regarding intensive surveillance for breast, thyroid, and renal cell carcinomas. Accurately recognizing the subtle systemic cutaneous or skeletal manifestations is the key to preempting a hereditary cancer diagnosis years before it evolves into a stage 5V incurable tragedy.
Okay, we have thoroughly established the molecular diagnoses. We have mapped the complex multi-system syndromes. Now we must steer this deep dive directly into the operating theater.
This is where it gets very mechanical again.
Right. How do these exact genetic profiles and lifetime risk percentages dictate the physical mechanical resection of the organ? How does the surgeon's scalpel answer the genetic threat? Let's begin by analyzing attenuated familial adenomatous polyposis, or AFAP.
AFAP presents a fascinating surgical dilemma because it is a milder, less aggressive phenotypic variant of classic FAP.
So they have fewer polyps.
These patients still harbor deleterious germline mutations in the APC tumor suppressor gene, but instead of developing thousands of carpeting adenomas in their teenage years, they might develop a few dozen to perhaps 100 polyps. Consequently, the inevitable malignant transformation to cancer occurs much later in life, typically in their 50s or 60s.
Because the risk of cancer is still exceptionally high, the preferred definitive treatment historically has been a total proctocolectomy. The complete surgical removal of the entire colon and the rectum, followed by the creation of either a permanent end ileostomy, meaning an external stoma bag on the abdomen, or the creation of an ileal pouch anal anastomosis, the IPAA, commonly known as a J-pouch.
But there is a major life-altering caveat here that colorectal surgeons must meticulously weigh with the patient.
What's the alternative?
If the surgeon performs a rigorous endoscopic evaluation and determines that all the adenomas located specifically in the rectum are larger than 5 millimeters and can be safely and completely removed via endoscopic polypectomy, a rectal-sparing surgical alternative suddenly becomes viable. We are talking about offering the patient a subtotal or total abdominal colectomy with an ileorectal anastomosis, a TAC IRA.
So leaving the rectum intact.
This decision hinges entirely on preserving the patient's long-term quality of life. An IPA is not a trivial procedure. It is a massive, highly complex, multi-stage pelvic surgery. It permanently alters gastrointestinal physiology. A patient with a functioning J-pouch might still experience 6 to 8 urgent liquid bowel movements every single day.
That's a huge burden.
Furthermore, the surgery carries significant long-term risks. Pelvic sepsis from occult leaks, chronic inflammatory pouchitis, and crucially for younger female patients, the extensive pelvic dissection and subsequent severe adhesion formation can drastically decrease fecundity, often necessitating in vitro fertilization if they wish to conceive.
So the TAC IRA avoids all that pelvic trauma.
If you can safely spare the rectum with a TAC IRA, you preserve the natural, highly distensible reservoir of the rectal vault. The surgeon simply connects the terminal ileum of the small bowel directly to the top of the preserved rectum. Postoperative bowel function is vastly superior, often near normal.
But there's a catch. Okay.
But, and this is the absolute non-negotiable trade-off, the patient still retains rectal mucosa that carries the inherited APC mutation. They are absolutely committed to a rigorous protocol of lifelong, invasive, annual endoscopic surveillance of that remaining rectum. If they become non-compliant with the surveillance, the retained rectum will inevitably develop a lethal adenocarcinoma.
It is a profound calculation weighing surgical morbidity and physiological function against the psychological burden of relentless oncological surveillance. Moving down the genetic spectrum, we encounter MEP-MUTYH-associated polyposis.
Yes, MYH.
This syndrome should be clinically suspected in any patient presenting with more than 20 lifetime adenomas. Genetically, it differs fundamentally from FAP. While FAP is autosomal dominant, MAP operates via an autosomal recessive inheritance pattern. A patient requires biallelic MYH mutations, deleterious mutations inherited on both maternal and paternal copies of the gene to manifest the severe polyposis phenotype.
Mechanistically, the MUTYH gene is a critical component of the base excision repair pathway. Normal cellular metabolism generates reactive oxygen species, which frequently cause oxidative damage to the DNA, specifically converting guanine to 8-oxyguanine.
Just from normal living.
Exactly. If this damaged base isn't removed, it will mispair with adenine during replication, causing a permanent mutation. MUTYH is the specific enzyme designed to recognize and excise that damaged adenine base. When both copies of MUTYH are non-functional, the oxidative damage accumulates rapidly, resulting in a polyposis phenotype that clinically mimics AFAP.
But the management is different.
However, the management strategy is distinct. For MAP patients, the consensus guidelines primarily recommend an aggressive protocol of annual colonoscopy with meticulous, complete endoscopic polypectomy to manage the polyp burden. You do not preemptively jump straight to a prophylactic total colectomy unless the sheer number and rapid growth of the polyps become technically unmanageable via colonoscope, or if a frankly malignant lesion is identified.
Now, let's address the true heavyweight of hereditary colorectal syndromes. Lynch syndrome. The surgical decision-making here is intensely debated among oncologists.
It is a constant debate.
The choice between a subtotal colectomy, which remains the most common approach, versus a more radical TAC IRA depends on a complex matrix involving the patient's age at presentation, the specific gene mutated, their calculated lifetime cancer risk, and again, their demonstrated adherence to intense surveillance programs.
Right, but the colon isn't the only organ at risk in Lynch syndrome.
And here's where the clinical algorithms become incredibly complex and emotionally fraught. There is a crucial, undeniable gynecological link in Lynch syndrome. If a female patient is identified as harboring a mutation in the MLH1, MSH2, or MSH6 genes, she carries astronomically high lifetime risks for developing both endometrial and ovarian carcinomas.
The stats are frightening.
To mitigate this risk, the oncological guidelines strongly mandate a prophylactic total abdominal hysterectomy with bilateral salpingo-oophorectomy, a TAH-BSO, starting around age 40, ideally timed to be performed concurrently with their necessary colorectal surgery.
It's a massive, life-altering intervention.
Here's where the textbook algorithms collide with brutal human reality. For surgical team managing a patient with Lynch syndrome, how do they practically navigate the decision to perform a prophylactic TAH-BSO on a 38-year-old woman, weighing the stark oncological statistics against her unfulfilled family planning desires, the immediate induction of surgical menopause, and the profound permanent impact on her overall quality of life?
It is arguably one of the most fraught, emotionally devastating conversations a surgical oncologist will ever have to lead. You are sitting in a consultation room across from a 38-year-old woman. Perhaps she is newly married, perhaps she desperately wants to conceive her first child.
Yeah, she has her whole life planned out.
And you are obligated by the data to inform her that by her 40th birthday, to mathematically ensure she survives the decade, the surgical team needs to completely remove her uterus and both of her ovaries. We are not just removing organs. We are inducing instantaneous, severe, irreversible surgical menopause.
The physiological crash must be intense.
That translates immediately to severe vasomotor symptoms, debilitating hot flashes, rapid acceleration of bone density loss leading to early osteopenia, significant alterations in long-term cardiovascular risk profiles, and the profound, often unquantifiable psychological trauma of suddenly losing her reproductive identity.
Not to mention the absolute permanent loss of biological fertility.
Precisely. The harsh logic driving this recommendation is dictated entirely by the brutal epidemiological statistics of Lynch syndrome. The lifetime cumulative risk of developing endometrial cancer for a patient harboring an MSH2 mutation can reach a staggering 60%. The risk of developing ovarian cancer can climb to 24%.
Can't we just screen for it, like we do with colonoscopies?
And here is the critical differentiating clinical factor. Unlike colorectal cancer, where we have the highly effective tool of colonoscopy to visualize, identify, and easily remove precancerous adenomatous polyps before they turn malignant, our screening modalities for ovarian and endometrial cancer are notoriously, tragically ineffective.
Really? What about ultrasounds?
Regular transvaginal ultrasounds and serum CA-125 biomarker blood tests simply do not possess the sensitivity or specificity to reliably catch these specific gynecological cancers at a localized, highly curable stage. They frequently fail to detect the malignancy until it has already spread throughout the peritoneal cavity.
So surgery is the only real option.
Therefore, radical surgical prophylaxis is literally the only proven definitive defense mechanism available. The surgical oncologist cannot manage this in isolation. The team must work intimately, hand in hand, with specialized reproductive endocrinologists to immediately discuss rapid in vitro fertilization and embryo cryopreservation if the patient has not completed her family.
It's a massive multidisciplinary effort.
Furthermore, they must coordinate closely with specialized gynecologists to medically manage the brutal physiological transition into surgical menopause, carefully utilizing hormone replacement therapy where oncologically appropriate to protect her bone and cardiovascular health.
It demands an immense capacity for empathy running parallel to absolute clinical rigor. The contrast with classic familial adenomatous polyposis, or classic FAP, is stark.
Oh, FAP is a completely different beast.
The surgical logic for classic FAP is terrifyingly straightforward, devoid of any gray area. The patient faces a near 100% certainty of developing colorectal cancer by age 30 if they do not undergo a prophylactic total or subtotal colectomy. There is no alternative surveillance strategy.
None whatsoever. The specific mutation in the APC gene driving classic FAP results in the unchecked development of thousands, sometimes tens of thousands, of adenomatous polyps carpeting the entire colonic mucosa.
Thousands of them.
Thousands! It looks like a shag carpet of pre-malignant tumors. It's not a statistical probability of if one of these polyps will acquire the secondary mutations necessary to turn malignant. It is a biological inevitability of when.
It's a ticking clock.
And tragically, due to the sheer volume of polyps, it is common for multiple independent primary carcinomas to develop simultaneously. Leaving the colon inside the patient's body is an absolute unavoidable death sentence. Therefore, the surgical timing is aggressive, usually mandating the radical prophylactic colectomy in the patient's late teens or early 20s to definitively preempt the malignant transformation window.
Before we transition away from the physical interventions used to destroy the tumor, we must address the role of radiation oncology, because there is a glaring, structurally dictated dichotomy in how we utilize radiation in the gastrointestinal tract.
Yes, the physics of radiation.
Radiation therapy is a heavy foundational component of the treatment algorithm for rectal cancer, specifically employing highly targeted, hypofractionated radiotherapy, often combined with sensitizing chemotherapy in the neoadjuvant setting, for stage 2 or 3 disease, or if the surgical margins are determined to be positive.
It's standard of care for the rectum.
However, radiation is practically useless and strongly contraindicated for colon cancer. Mechanistically, why this massive discrepancy?
It is entirely a problem of pure physical mechanics and surrounding anatomical structures. The rectum occupies a very specific anatomical space. It is deeply anchored within the rigid, bony confines of the pelvis. It is relatively fixed in place, surrounded and buffered by dense pelvic bone and a thick envelope of mesorectal fat.
So it's locked in position.
Because it doesn't move, a radiation oncologist can utilize advanced imaging to map the precise three-dimensional contours of the tumor, calculate the optimal intersecting angles for the external beams, and deliver a massive, highly targeted, sterilizing dose of ionizing radiation directly to the rectal tumor bed, while tightly minimizing the scatter and damage to adjacent vital structures like the bladder or sphincter complex.
But the colon operates in a completely different physical environment.
The colon is essentially a mobile tube suspended dynamically by a sheet of tissue called the mesentery. It moves. It changes position based on patient posture, respiration, and the passage of gas and stool. It literally floats around within the massive space of the abdominal cavity.
It's a moving target.
Furthermore, and critically, the colon is intimately surrounded by and constantly touching yards of highly mobile small intestine. The mucosal lining of the small intestine is exquisitely, notoriously sensitive to ionizing radiation. Its cells divide rapidly and are easily destroyed by the beams.
So if you try to radiate the colon,
If a radiation oncologist attempts to irradiate a tumor located in the highly mobile colon, they cannot guarantee the target will remain stationary. They are invariably, unavoidably going to blast the adjacent loops of small bowel with high-dose radiation.
and that's catastrophic.
This causes severe, irreversible radiation enteritis, leading to massive mucosal sloughing, dense stricture formation, bowel obstructions, the development of complex fistulas, and catastrophic life-threatening damage. The fundamental mechanical limitation of the colon's inherent mobility makes safe, targeted application of curative radiation physically impossible.
It makes complete sense when you visualize the anatomy.
Therefore, for colon cancer, and specifically for conditions like FAP and Lynch syndrome, we demand absolute precise surgical extirpation with the scalpel because radiation is completely off the table as a curative modality, barring very specific localized palliative exceptions like treating isolated bone metastases or brain lesions.
That structural reality perfectly illustrates why immaculate surgical technique is so paramount in colonic resections. The surgeon doesn't have radiation to act as a safety net to clean up positive margins. So we arrive at the final phase. The complex surgery is completed. The grueling chemotherapy regimen is finished. The follow-up scans show clear margins and no visible disease.
But the story doesn't end there.
No. As you emphatically noted in your preparatory research for this deep dive, achieving a clear scan is only the conclusion of the first chapter. We must conclude this discussion by confronting the harsh statistical reality of what actually happens after the medical intervention ceases, the aftermath, the prolonged reality of complications, prognosis, and survivorship.
This is perhaps the most overlooked aspect of oncological care. The interventions we have detailed today, the FOLFOX regimens, the radical colectomies, the targeted inhibitors, are undeniably life-saving. They alter the course of lethal diseases. But they are emphatically not benign. We have an ethical obligation to be completely honest about the profound physiological and psychological toll these interventions extract from the patient over the ensuing decades.
Let's ground this in the hard numbers. Even a procedure considered as ubiquitous and routine as a surveillance colonoscopy carries inherent significant risks. The data shows that immediate severe complications, specifically iatrogenic perforation of the bowel wall or uncontrolled severe hemorrhage, occur at a rate of approximately 3.3%.
And those aren't just random events.
Right, the recognized risk factors for these events are exactly what a clinician would anticipate. A documented history of severe colon disease or diverticulosis, the patient actively taking systemic anticoagulation medications, a history of prior complex pelvic surgery causing dense adhesions, previous abdominal radiotherapy causing tissue friability, or a concerning history of a previous colonic perforation.
A 3.3% severe complication rate might sound relatively low to a layperson casually reviewing a consent form, but you have to view that percentage through the lens of population health.
Because of the sheer volume of procedures.
When you are managing a national colorectal screening program or executing intensive, lifelong surveillance protocols for thousands of Lynch syndrome patients, performing millions of these endoscopic procedures annually, that 3.3% translates into tens of thousands of individual patients suffering catastrophic events and ending up in the emergency resuscitation bay.
It's a massive absolute number.
An iatrogenic perforation is not a minor hiccup. It instantly triggers massive peritoneal contamination. It requires an immediate emergency exploratory laparotomy, a highly morbid washout of the abdominal cavity, and frequently the creation of a temporary or permanent diverting stoma. It is a massive, life-altering physiological hit resulting directly from a preventative screening tool.
And when we scale up from endoscopic screening to the major prophylactic surgeries we discussed, the complication risks climb steeply. Following a total colectomy, the rate of severe systemic complications reaches 22%.
It's almost a quarter of the patients.
This incidence is particularly concentrated in the over 65 age bracket, patients who often present with existing cardiopulmonary comorbidities. We are documenting high rates of postoperative pneumonia, perioperative myocardial infarctions induced by surgical stress, and massive deep vein thrombosis. Furthermore, the specifically surgical complication rate failures of the physical procedure itself stands at a daunting 8%.
And those are devastating failures.
This category encompasses major deep space wound infections, life-threatening postoperative hemorrhage, and the most feared outcome, the anastomotic leakage. I want to dwell on the pathophysiology of the anastomotic leak for a moment, Because in surgical oncology circles, that is universally acknowledged as the absolute nightmare scenario.
It is the absolute paralyzing dread of every colorectal surgeon on the planet. And anastomosis is the critical juncture where the surgeon manually sews or mechanically staples the two remaining ends of the viable bowel back together to restore gastrointestinal continuity.
To reconnect the plumbing.
A leak occurs when that delicate tissue connection fails to heal or physically breaks down in the days following surgery. When an anastomosis leaks, raw liquid feces and massive loads of highly virulent enteric bacteria spill freely and continuously into the normally sterile environment of the abdominal cavity.
Instant peritonitis.
The physiological response is violent and immediate. It triggers overwhelming diffuse peritonitis. The patient rapidly descends into profound systemic inflammatory response syndrome, severe septic shock, and rapid multi-organ failure. The mortality rate from a major unrecognized anastomotic leak is terrifyingly high.
How do you even manage that?
Managing it almost always requires an emergency return to the operating room under dire conditions, a massive surgical washout of the infected abdomen, the complete dismantling of the failed anastomosis, and the creation of an endostomy to divert the fecal stream. It is precisely why that critical 6 to 8 week delay for initiating adjuvant cytotoxic chemotherapy, which we discussed at the very beginning of this deep dive, is so utterly non-negotiable.
Because you can't compromise that healing process.
Yeah. You absolutely cannot introduce agents that impede cellular replication while that critical anastomosis is desperately trying to establish structural integrity.
The interconnected logic of the timeline is fascinating.
Yeah.
Now, assuming the patient successfully navigates the perilous surgical recovery window and completely avoids those catastrophic complications, we look toward long-term prognosis. And here we encounter a truly fascinating, counterintuitive statistical paradox.
The Lee et al. Paper.
Yes, we have a highly cited epidemiological study by Lee et al. That focused specifically on sporadic colorectal cancer patients. The study revealed that patients who presented with a documented family history of colorectal cancer consistently demonstrated a significantly better overall survival rate than patients without any family history.
But the recurrence rates.
Yet, and here's the profound statistical kicker, the data showed that both groups possessed exactly identical rates of cancer recurrence. So, I need you to apply your analytical framework to this. If the biological recurrence rates of the tumors are exactly the same, why on earth are the patients with the family history surviving significantly longer?
This specific paradox forces us to critically examine the hidden biases inherent in observational survival data. It demands deductive reasoning. If the actual biological recurrence rate is identical between the two cohorts, we can reasonably deduce that the intrinsic tumor biology, specifically its fundamental aggressiveness and tendency to metastasize, is likely similar.
So the tumors behave the same way.
Right. So we must ask, what external variables account for the stark survival gap? There are 3 highly robust hypotheses. First and foremost is the phenomenon of heightened vigilance, which introduces a classic lead time bias.
How does that work in this context?
A patient carrying a known family history has likely watched a parent, a sibling, or an aunt suffer through the brutal reality of this disease. Consequently, when they finish their own primary treatment, they are exquisitely hyper-aware of every single subtle somatic symptom. They do not miss their scheduled follow-up oncology appointments. They undergo their surveillance CT scans religiously.
They're watching like a hawk.
Therefore, if their cancer does biologically recur, that recurrence is detected on a scan at the earliest possible microscopic stage, long before it becomes clinically symptomatic. Because it is caught so early, aggressive salvage therapies like targeted liver resections or localized ablations are significantly more effective.
So they're diagnosed with the recurrence earlier, meaning their calculated survival clock starts ticking earlier, making it appear statistically as though they lived a longer lifespan from the point of recurrence diagnosis, even if the ultimate time of death isn't drastically altered.
Precisely. That is the definition of lead time bias. The second major hypothesis centers on the psychosocial environment. Families burdened with a strong history of a specific hereditary disease often organically develop robust, shared health-seeking behaviors. They possess established, highly supportive nutritional and emotional networks.
They know the system.
Crucially, they possess a higher degree of health literacy regarding their specific disease, meaning they're far more likely to aggressively and effectively advocate for themselves within a complex, often bureaucratic medical system to secure rapid access to advanced clinical trials or novel targeted therapies.
And the third hypothesis.
Finally, we must maintain humility regarding the limits of our molecular sequencing. There could exist a subtle yet unmapped biological difference. Perhaps the recurrent tumors that develop in the family history cohort, despite recurring at the exact same frequency, possess an underlying, uncharacterized genetic predisposition that renders them inherently more susceptible to second or third-line palliative chemotherapies.
So there might be a genetic soft spot we just haven't found yet.
Yeah. It is a brilliant cautionary example of why a clinician can never simply accept a Kaplan-Meier survival curve at face value without rigorously interrogating how the patients in each cohort actually navigated their disease course.
Which naturally brings us to the final, sobering aspect of the aftermath, the reality of survivorship. We are looking at data evaluating patients 5 to 10 years post-diagnosis. The headline statistics usually suggest they generally report a good overall health-related quality of life.
But you have to look deeper than the headline.
But when you dissect the data beneath that optimistic headline, there are stark, debilitating deficits. These patients report significantly, persistently poor social functioning compared to healthy age-matched controls. They suffer from a constellation of chronic, grinding physical issues, dyspnea, chronic shortness of breath, along with relentless chronic constipation, alternating with severe diarrhea, largely secondary to the permanent anatomical rearrangements from surgery and the fibrotic scarring from pelvic radiation.
The physical toll is immense.
And notably, younger individuals in the survivorship cohort report suffering from severe, often insurmountable financial challenges.
The oncological community has formalized a term for this: financial toxicity. The sheer out-of-pocket costs associated with the highly advanced, life-saving targeted therapies we praised earlier, drugs like an encorafenib or pembrolizumab, are astronomical, even with robust insurance coverage.
Especially if they're diagnosed young.
Younger patients, particularly those with hereditary syndromes who develop cancer in their 30s or 40s, are struck by this disease precisely during their peak career earning years. They lose massive amounts of potential income from taking extended leaves of absence to endure complex surgeries, prolonged chemotherapy regimens, and recovery from severe complications.
It derails their entire life trajectory.
They rapidly deplete their life savings, often liquidating retirement accounts to cover copays. Furthermore, they frequently face permanently altered downward career trajectories because the chronic crushing fatigue or the unpredictable urgent bowel dysfunction prevents them from returning to high-stress or physically demanding professions.
So they survive, but at what cost?
They technically survive the cancer, the scans are completely clear, but the price of the cure leaves them economically and socially devastated. And that profound social functioning deficit is inextricably linked to the physical bowel issues. If a patient is constantly terrified of experiencing a catastrophic diarrheal accident in public because their rectum was surgically removed or heavily irradiated, their behavior changes drastically.
They isolate themselves.
They stop going out to restaurants, they stop traveling, they avoid social gatherings. Their entire lived world shrinks dramatically to the safe radius surrounding their home bathroom.
It is a profound, sobering reminder for every practitioner that declaring a patient statistically cured of their malignancy absolutely does not mean that the patient is fully healed.
It's a vital distinction.
Okay, we have covered an incredibly massive amount of dense, complex ground today. For the dedicated listener navigating this material, whether you are walking into your PhD defense committee room tomorrow or staring down the FRCS board examiners next week, I want to sincerely congratulate you.
You've made it through the labyrinth.
You have just successfully navigated an intense, highly rigorous labyrinth of modern oncology. We journeyed from interpreting the exact molecular hazard ratios of FOLFOX and FOLFIRI to understanding the deep embryological lineage that dictates tumor-sidedness and anti-EGFR efficacy.
We unpacked the complex immunological mechanism behind the chemotherapy paradox of MSI-High tumors.
And marveled at the breathtaking, unprecedented success of neoadjuvant checkpoint inhibitors in the niche trials. We linked the localized pathology of the gut to the brain and skin through the PI3-KPTN pathway mutations, and we rigorously weighed the brutal, human-level surgical algorithms for FAP and Lynch syndrome against the harsh, long-term realities of severe complications and financial survivorship.
The true value of the deep dive we have executed today does not lie simply in memorizing isolated data points or repeating statistics. It lies in your newly acquired ability to completely understand the profound biological why beneath the clinical guidelines.
That's what separates the good from the great.
When an examiner aggressively questions why you absolutely must delay adjuvant chemotherapy for exactly 6 weeks, or why you refuse to administer cetuximab to a genetically identical right-sided tumor, You now possess the complete pathophysiological architecture to not just recite the answer, but to entirely command the topic.
And as we close, we want to look forward, not backward. Given everything we have discussed, I want to pose a final question regarding the trajectory of our field.
I think I know where you're going with this.
We extensively analyzed the neoadjuvant immunotherapy data in Section 2, specifically those astonishing niche trials demonstrating a 95 to 97% major pathologic response rate, essentially total tumor eradication, with 0 recurrences for MSI-H early-stage colon cancer. And we sharply juxtaposed that molecular triumph with the brutal, physically devastating surgical realities of prophylactic proctocolectomies, the creation of J-pouches, and the nightmare of anastomotic leaks we discussed in Section 4. So looking at those two converging realities, I have to ask, are we rapidly approaching a definitive point in the future where the radical, life-altering, physically destructive surgeries we routinely perform today become completely obsolete for a highly specific subset of genetic profiles?
It's the ultimate question.
Will we see a day within our careers where the surgeon's scalpel is entirely replaced by the precise administration of immune checkpoint inhibitors?
It is arguably the most exciting, fundamentally disruptive, and fiercely debated question in all of colorectal oncology today. And based on the staggering trajectory of the pathological complete response data we are observing, the obsolescence of radical surgery for specific molecular profiles is no longer just theoretical science fiction. It is an impending, inevitable clinical reality. We are witnessing the dawn of an era where molecular precision finally outpaces mechanical resection.
Keep questioning the published data. Keep digging relentlessly into the underlying cellular mechanisms, and keep mastering the absolute depths of your field. Because the answers you uncover are going to completely redefine what is physically possible for these patients. Remember, the anatomical radiograph might be broken, but the precise molecular signature is illuminating a completely new, infinitely more hopeful path forward. Thanks for joining us on this deep dive. We will see you next time.